I was just saying, I think it might be right for us to take this back internally, and review your questions, review the comments, and review the evidence that we use to develop this policy again. Make sure that we are able to answer these questions that are coming up, because I do think that we do have the opportunity to kind of regroup on this and kind of better address your questions by being able to kind of cite the evidence and how we are planning on presenting this policy going forward.
How does that sound to the committee?
That sounds good to me, Ryan. This is Alex Park. It sounds good, but here's a question. So while we are in holding pattern with this policy, what's the existing policy where patients with ALS need to follow if they need this drug?
Hi, this is Ryan Pistoresi. So great question. We are receiving requests for this drug, and we are reviewing them for medical necessity. So without getting into specifics about the cases that we've seen, we are looking at using this criteria, but also looking at clinical judgment and seeing if these patients meet this, or if they're close, to consider the rationale for approving it or for continuing care. So we are receiving it and using this kind of as a guideline, but not as a set policy.
I see. So are you saying that there is no set policy now? It's sort of a one-on-one assessment?
Yeah, this is Ryan. So before we have, a finalized clinical policy, if a drug comes to us, while we're developing a clinical policy, or if it's a new pipeline drug in which there is very limited evidence, we do tend to look at those on a case-by-case basis. And so we can review and approve drug requests before we bring like a policy that is final to the DUR board and for it to be approved. And those are really done more on a case-by-case basis, really looking at the evidence and looking at the case that is being presented to us, and knowing that at this time in which there is very limited evidence to look at the clinical circumstances of these cases. So sometimes we do see patients that were started on a drug in a clinical trial, and then we get the request once that drug has been approved. Other times we do get some cases that they may not have met that clinical criteria that was in the study, but we may see that it's being evaluated on an ongoing clinical trial. So we do try to look at that and then at the same time develop a clinical policy that we can bring to you.
This is Ginny. So if I'm hearing the committee correctly, it sounds like the preponderance of thought is to continue to ask for a little more information. Is that right?
This is Nancy. Agreed.
Okay. Do we need to make a motion then, as I see it being updated down there?
Hi, this is Marissa. So I'm thinking maybe we don't make a motion on this one if it's something that needs to be re-reviewed and re-presented again. So I just went ahead and updated the slide for our reference, but we won't proceed with the motion for this particular policy.
Thank you, Marissa. Okay, so we will go ahead and move on. And so our next topic will be pulmonary arterial hypertension agents, specifically prostacyclin, with Marissa.
Hi, this is Marissa. Just bear with me 1 minute. I just need to open up the policy and the form. Okay, great. This is Marissa. So, hello, DUR board members. I will be presenting the pulmonary hypertension agents oral inhalation policy. So just to give you some background on this policy, this is an annual update of our current policy that we have implemented. And the current policy that we have posted online and implemented was effective August of 2018. So it has been about 2 years since this policy has been reviewed. And just to give you some reference on this policy, we did add a new agent that was approved in 2019, which is ALEEK, and I apologize for the mispronunciation, but it is tadalafil formulation or product. And what caused the update for this particular policy was just this policy was the current policy that we have right now is a little bit broad. All it really asks for is just a diagnosis, and that would just be a broad diagnosis of pulmonary arterial hypertension, as well as have you tried and failed sildenafil. So this policy now with the update I will be presenting is really asking for a little bit more specific criteria. And then we also included some World Health Organization classifications to the policy. It's not previously on there, but in this update, it is listed there now. And with the current policy that we have right now, we do have chronic thromboembolic pulmonary hypertension separated out from the pulmonary arterial hypertension. So if you look on the policy, there are two separate indications, but just to make it a little bit more concise, we have combined them. So now it looks like a more concise policy for this update. So I won't get into any of the background. I think Umang did a really great job of talking about the disease state. So I'll just get right into the clinical criteria and the updates. So for this policy, we have now added, like I stated, the World Health Organization classification. So now if a patient has PAH diagnosis group 1, that is included, and we have also broken it out into the WHO functional class, which is listed here. So we require documentation of their functional class as well as their group. And if they have had, the patient has any acute vasoreactivity testing and the status of that test. That was not previously included in the policy that we have right now. So this testing requirement is included, and that testing would be if the patient had a positive response to ABT but had an inadequate response or intolerance or contraindication to amlodipine, diltiazem, or long-acting nifedipine, or if a patient had a negative response to ABT testing, or if ABT testing is not indicated for the patient. So if they have PAH due to connective tissue disease, congenital heart disease, HIV, portal hypertension, pulmonary veno occlusive, or pulmonary capillary hypertension, or if acute vasoreactivity testing is contraindicated in the patient. We have also now included, like I said, the CTEPH criteria is kind of put in one now. So now we have a different, if they have a different diagnosis of pulmonary hypertension, diagnosis in groups 3 or 4, and 4 specifically for CTEPH, in which general treatment measures have failed and pulmonary hypertension is thought to be unrelated to underlying lung disease. And then we also have added criteria for if they meet one of the following. So if they are currently on a medication or documentation that the patient is currently established on a requested therapy. So if they're already taking it, that's means for approval. Like Umang had stated, you don't want to stop any PH treatment abruptly. So that is kind of where that criteria has come from. If a patient is requesting for a non-preferred product, of course, it would require a history of failure, contraindication, or intolerance to a preferred product with the same Apple Health drug class, of course, where that is applicable. And then for Uptravi or Selexipag specifically, we would require a history of failure, contraindication, or intolerance to an endothelin receptor antagonist. That has been included in the criteria now. And we've also included this criteria number 4, where the requested therapy is not for any of the following. So it would be a combination of a PDE inhibitor and soluble guanylate cyclase stimulator, and a combination of Selexipag and parenteral prostanoid. And then criteria 5 has not changed. It's still the same, prescribed by or in consultation with a specialist in cardiology or pulmonology. So if the patient meets the criteria, then the request will be approved for 12 months. And we have added this statement as well. You'll see it, you've seen it on some of the other criteria today, where if all the criteria are not met, but there's a documented medically necessary circumstance based off of the professional judgment of the clinical reviewer, then of course cases can be approved or requests can be approved on a case-by-case basis up to the initial authorization duration. And another change for the reauthorization criteria is just that right now, I believe our criteria just says a positive clinical response, but it's not specific to kind of what that response looks like or what we would be looking for. So we got a little bit more specific in the language. So it can be reauthorized if there is documentation of response. So if there's disease stability or mild progression indicated by a slowing of decline using the WHO functional class, if that's provided, and then it can be reauthorized again for another 12 months. And so here are some of the codings, the HCPCS codes, the dosage and quantity limits, and this has been added into the policy as well. So we've added an appendix with the WHO clinical classification of pH as well as the functional classification, just for reference for some providers. So that is now included in the policy. And then moving over to the form. So this is a form for this particular criteria. I'm not entirely sure what the form looks like right now, but this is to help kind of guide providers through what the criteria we're looking for, what a patient would need to meet in order to get these medications. So of course we ask now for the World Health Organization class and the functional class, what group, the specialty of the provider, do they have a vasoreactivity test, what were the results, do they have a history of any of the following, so are they currently taking a PAH agent, do they have failure or contraindication to a preferred product, then it lists which product. If it's for an Uptravi request, does the patient have a history of failure, contraindication, or intolerance to an ERA? And then it asks, of course, will this be used in combination with any of the following? So I'll go ahead and pause for any feedback from the committee.
Thanks a lot, Marisa. Committee, any questions about the form or the policy? And I don't see any stakeholders listed. Oh, go ahead, Alex.
Thanks, Ginny. Marisa, quick question. I just want to make sure I understand this correctly. So it's meeting criteria number 1 or 2, and one of the ones under 3. Is that right?
Hi, this is Marisa. Yes, Dr. Park, that is correct.
Okay. So then under number 3, it says documentation that the patient is currently established on the requested therapy. So does that mean that the drug that they're requesting, they have to already be on it at the time that they're requesting this authorization?
Hi, Dr. Park, this is Marisa. Yeah, so this really covers for patients that are kind of already on a PAH agent. So if they were referred again, then we would just need documentation that it's pretty much like a continuation of therapy.
Okay, thanks for clarifying. Is there a separate policy for initial authorization?
Hi, this is Marisa. No, we don't have, well, the only thing we have right now is the current policy that's posted online, and that's pretty broad as far as the criteria that they have. It's just, do they have PAH? Have they failed sildenafil? And I'm trying to think of what some of the other criteria are, but it's pretty broad. So if they met that criteria and say this policy goes into effect, then if they've taken it before or gotten approved in the past, then it would just have to show that they've gotten this medication, they have a medication history of getting it, and then it would get approved.
And what if I'm a pulmonary arterial hypertension patient, I've never been on one of these drugs, and I don't meet that 3rd criteria? In other words, I can't document that I'm currently established on any of those treatments, but I want to get on one of them. How does that work?
Sorry, could you repeat your question one more time?
I'm just imagining if I was a patient with this disease, not having been on one of these agents before, so I can't give you documentation that I'm currently established on the requested therapy. But me and my provider think I should be starting it. What would the workflow be in that case?
So this is Marissa. Maybe just to clarify, I guess number 3 is as long as they have one of any, so one of these 3. So if you're a patient and your provider is requesting for a non-preferred product, then of course we would try to steer you into a preferred product first before you can get approved for a non-preferred product.
Thank you very much. I missed the ORs among A, B, and C. That makes sense. It's late in the day. Okay, thank you.
Thanks,
Actually,
Alex.
this is Donna. So Marissa, I want to look at that one more time, because I think what is happening is that there's no, is this prior authorization only for non-preferred products or preferred drugs on PA as well?
It's for preferred and non-preferred products, Donna.
Okay, I think that Dr. Park was correct that that pathway doesn't lead you to being approved for a preferred drug. So I think that they're either treatment naive and the request is for a preferred drug, or there's documentation that they're currently on a non-preferred drug, or they've had a history of trial and failure for a non-preferred drug would be the appropriate pathway.
Hi, this is Marissa. So will we need to include language for a preferred product? Is that kind of what you're
we'll take
say?
that back. So like number A or letter 3A would be, patient is treatment naive and the request is for a preferred drug.
Okay.
Or then blah, blah, blah. So good catch, Dr. Park.
Thanks, Donna. I didn't quite say it as well as you did.
Yeah, I was.
Well, I definitely didn't say it as well as you did.
I wasn't quite following you until I read through it one more time, and it was like, oh, there is no way to get to a preferred drug.
Yeah, thanks.
Yeah, thanks for pointing that out, Dr. Park. I apologize. It took me a minute to process what you were saying. Thank you.
Well, I got confused myself when you showed me the ORs, and I thought maybe I was being mixed up, but I'm glad this is why there's more than a couple of us on this committee, so thank you.
This is Ginny. Thank goodness for many minds. So that will be held as well, and we then can move to the respiratory agents for cystic fibrosis. Is that correct?
Hi, Ginny, this is Marissa. We do have the motion still.
Oh, okay.
So, yeah, so if we add the language.
Okay, that's fine. I just misunderstood. I thought there needed to be more work done to the policy before we move to the motion. Or if it's simply that wordsmithing, then and we can go ahead.
Yeah, I think it could probably, it's just the wordsmithing for that. So we'll just make sure that what Dr. Park had said gets added to the policy with the preferred product language, or having a pathway to coverage for the preferred product. So I will put that into the criteria or into the motion.
Okay, good. Then that's just fine. I don't see any stakeholders listed. So when you're ready, we'll go to the motion.
It seems to, this is Jordan Starhawk. It seems to me that it's going to probably take some pretty big movements to make this happen. I'm wondering if it would be possible to have that wordsmithing done and us just vote about it next time to see what it kind of in its final copy.
This is Ginny. That's fine with me.
This is Alex Park. I'm on board with that too, Jordan.
Marissa is gone. Maybe she's had enough. I don't know.
Oh dear.
Oh dear. Oh, but there's movement.
She just texted me. She lost connection.
Okay.
This is Donna. I just lost audio.
I can hear now. I couldn't hear anything for a second, but it seems like I'm back.
Oh, great.
And this is Marissa. Jeannie, can you see the motion up, or can the board members see the motion?
Yes, this is Ginny. I can see it. Donna had started to speak at one point, and I just wanted to.
No,
sure.
I was going to say I had lost audio, and so if you were trying to talk to me, I couldn't hear anything for a minute.
All right, well, let's hop on this motion then while we've all got some sort of connection.
Well, I guess I had kind of made the request that we'd hold off on it unless it wouldn't be possible for us to see that pathway. I think most of the time when we're changing things, it feels like we're just taking or moving and changing an and to an or, but it seems like the flow of this document is going to change to be able to get a preferred product pathway. So if we could see it next time, that'd be my preference, unless we have pressure.
This is Ginny. I agree completely, and my apologies that I flipped back to I completely, yes, lost track of where we were. So I'm in absolute agreement with that, unless there are any other concerns from anybody else. Okay. All right then. So we will go ahead then and move as a group to the respiratory agents.
Hi, Jenny, this is Marissa, I just wanted to confirm that we're not making a motion, right? You wanted to have this represented. Okay.
Yes, you are correct.
Okay, great. Let me go ahead and open up the cystic fibrosis agents policy. This is Marissa, my apologies. Sorry, my computer is thinking. I will have them up as soon as I can.
All right. Can you hear me?
Yes, we can hear you, Luke. Go ahead.
Great. This is Luke Dearden, and I will be presenting the cystic fibrosis agent policy. So a little background to start off with. Cystic fibrosis is characterized by mutations in the cystic fibrosis transmembrane conductance regulator, CFTR gene, which primarily causes dysfunction, among other things, of the chloride ion transport across epithelial linings. And as a result, thick mucus buildup occurs in the lungs, among other organs as well. And CFTR modulators are relatively recently approved oral medications that are approved to treat cystic fibrosis. So in the medical necessity section here, it outlines each CFTR modulator FDA approved indication, which is slightly different depending on which CFTR gene mutation the patient has. So we can move down to the clinical criteria. And this is a new policy, by the way, I forgot to mention that. So the first, the criteria includes diagnosis of cystic fibrosis, appropriate CFTR gene mutation, depending on the medication. So for example, at least one responsive mutation for Kalydeco or Symdeko, and those are outlined in Table 1 in the appendix. Also, homozygous F508DEL mutation for Symdeko or Orkambi. And just to note that that specific mutation is responsible for about 50% of cystic fibrosis cases. And then finally, for Trikafta, there has to be at least one F508DEL mutation, and that encompasses about 90% of cystic fibrosis cases. Moving on to criteria 3, appropriate age depending on the medication, baseline BMI, FEV1, and LFTs for number 4. Number 5, no severe hepatic impairment, and we're talking about really decompensated cirrhosis here, Child-Pugh class C. Baseline ophthalmic examination for pediatric patients, and that's because they've discovered a possible risk of cataracts in that population with these medications. So ongoing monitoring is needed for that. Number 7, patient hasn't had a lung transplant, and then not taken with a strong CYP3A inducer, which is a contraindication for these medications due to the drug interaction, and then prescribed by a qualified provider. Then if you could scroll down a little bit, we have a section here just outlining the requirements if somebody wanted to switch from say Symdeko or another medication to Trikafta. They basically, it is allowable. They have to meet all of the initial approval criteria for Trikafta above, and it won't be effective until at least 85% of the patient's current supply of medication has been depleted. And then if we could move down to the reauthorization criteria, which just includes factors that represent disease state improvement or stabilization. So improvement in FEV1 over baseline, decreased pulmonary exacerbations or infections, decreased hospitalizations, increased weight or growth, or just a decrease in the decline of lung function. And if we scroll down, we have the dose and quantity limits. I will note here that use of CYP3A inhibitors would require a reduced dose or a reduced dosing regimen of these medications. And then if we keep scrolling down, we have the responsive mutations to Kalydeco and Symdeko, and then a list of CYP3A4 inducers, which are contraindicated with these medications. And that's it for the policy. And we can review the form here. So I will allow the committee to read through the form, and I would direct it back to them for any feedback or questions.
Thanks, Luke. I want to make sure that the committee gets a chance to ask questions. I also wonder, we have 2 stakeholders listed, so I do want to make sure we get time to hear from them. We have both Dr. David Ricker with Marybridge Children's Hospital and Lisa Allen with Vertex Pharmaceuticals. Lita, are you able to see if either of our stakeholders are present?
Yes, sorry, I'm looking him up right now. Okay, don't see David. Okay, Lisa Allen, I am unmuting you.
Are you there, Lisa?
Thank you. Yes, thank you. Can you hear me, Jenny?
Yes, I can, Lisa. Thanks. If you can just state your affiliation and let us know if you have any financial disclosures to make, and then you'll have 3 minutes to speak.
Thank you very much. My name's Lisa Allen. I'm with Vertex Medical Affairs. I'm employed by Vertex, and so that is my potential conflict of interest. Thank you for the opportunity to provide public testimony on behalf of cystic fibrosis transmembrane conductance regulator modulators for the treatment of patients with CF. I would like to begin by thanking the committee for continuing to list Kalydeco, Orkambi, and Symdeko as preferred drugs in alignment with their FDA-approved indications. Today, I'll focus my testimony on Trikafta, which is the triple combination of elexacaftor, tezacaftor, and ivacaftor, indicated for use in patients with CF 12 years and older who have at least one F508del mutation in the CFTR gene. I respectfully request the committee to add Trikafta to the preferred drug list. The rationale for this request is based on the available clinical evidence from 2 phase 3 clinical trials. In trial 2, a randomized double-blind study of patients homozygous for the F508del mutation, treatment with Trikafta resulted in a significant improvement compared to Symdeko in lung function as measured by the absolute change in FEV1 at week 4. Both key secondary endpoints, the reduction of sweat chloride levels and clinically meaningful increases in CFTR, were also achieved. More recently, results of a post-marketing phase 3 study of Trikafta in patients with 1 copy of F508del and a gating or residual function mutation showed that treatment with Trikafta resulted in a significant improvement in FEV1. This improvement was in addition to any benefits that patients may have had from existing CFTR modulator treatment with Kalydeco or Symdeko. The warnings and precautions associated with the CFTR modulators have been shared with this committee previously and are found in Section 5 in the USPI for each medicine. These include important information on liver function test elevations, drug interactions, and cataracts. Elevated transaminases have been reported in the CFTR modulators. Bilirubin elevations have also been observed with Trikafta treatment, so guidance around the monitoring of LFTs are included in the USPI. If patients experience significant elevation of LFTs, there's also guidance for interrupting the CFTR modulator. Cases of cataracts have been reported in pediatric patients treated with ivacaftor-containing regimens. Therefore, baseline and follow-up examinations, as Luke mentioned, are recommended with all 4 medicines. Additionally, for Orkambi, the warnings and precautions include information on use in patients with advanced liver disease, respiratory event, and effects on blood pressure. Finally, I would like to respectfully request the committee to consider removing initial approval criterion number 7, which is related to patients who have received a lung transplant from the clinical policy. As lung transplant is not a contraindication in the USPI for any of the CFTR modulators. Based on this clinical evidence, I respectfully request the committee to add Trikafta to the PDL in accordance with the FDA-approved indication and update the clinical policy to allow access for CFTR modulators to eligible patients who may have received a lung transplant. Thank you for your time, and I'm happy to answer any questions you may have.
Thank you, Lisa. Are there any questions from the committee for Lisa Allen? Okay, so we can turn our attention, unless Dr. Ricker has appeared on.
This is Lita. I don't see him.
I wanted to be sure I didn't miss him. So committee members, why don't we turn our attention back to the form and to the policy and see if there are any questions for Luke. So I don't hear any questions. Do we feel ready to move to make a motion?
Stakeholder comment regarding lung transplant.
Can you repeat that? Sorry, you were cutting out.
Of course, sorry. Can you comment on the stakeholder comment regarding the restrictions after lung transplant?
Yeah, number
Yeah,
7.
so the rationale for adding that is that there is really very limited to no data using these medications in this population. And in fact, there is, I guess, limited to anecdotal evidence that at least TRICAFTA can worsen outcomes in the setting of lung transplant. And then the other consideration here is that the immunosuppressant drugs such as cyclosporin, everolimus, etc., do interact with these medications quite severely, especially Orkambi. And it is tough to manage those drugs appropriately when these are also being prescribed. However, with that being said, as we've brought your attention to the paragraph at the end of this clinical criteria many times today, that situation could be reviewed on a case-by-case basis by a clinical reviewer.
Thank you.
So this is Constance. So Luke, you were mentioning that, so number 7, that the lung transplant criterion was placed because of lack of evidence of showing efficacy. Is that correct?
Just lack of data in general when used in this population. That was one of the reasons, yes.
If that's the case, then I would actually think it shouldn't be there if we don't have enough evidence for it, yay or nay. So if you drafted this or based off of, you're representing HCA, what the point is of having that clause? Is it to protect patients that, potentially could have an adverse outcome even though there isn't evidence to support that?
So as I mentioned earlier, there is some anecdotal evidence, or I would actually say limited evidence, that TRICAFTA worsens outcomes in this population. This is something that I could take back and review more as well. And then also I mentioned the serious drug-drug interaction concerns where use of the immunosuppressants post-transplant, the levels can be very unpredictable, as some of these, for example, Orkambi has both a CYP3A for inducer and inhibitor. So there is that drug-drug interaction concern as well, realizing that it is very important in that post-transplant setting to maintain levels of those medications.
Okay, thank you, Ryan. I know you probably said that 3 times and eventually it'll stick. So
I will say though that I am open to feedback around this specific criteria, and if the committee thinks that it should be taken out, I have absolutely no problem with that.
And hi, this is Donna. I'm actually think the one that put this in there. In one of the labels of one of these products, it is actually in the product label that it's not recommended in patients for lung transplant. So I would like to go back and do a little bit more research on that.
And
I want to say the issue with the ivacaftor ingredient within the product.
That medication is the Orkambi, like I said, that is actually contraindicated in this population. However, not only lung transplants, it would apply to all transplants, I will admit.
So this is Constance again. I appreciate you, Luke, saying that it was, there's some anecdotal evidence, right? Because, we probably experienced certain reactions and have heard stories or personal experience with our patients and certain medications, and it potentially couldn't be used as kind of a flat type of understanding that it would happen across the board. So I appreciate you guys looking into that. And if it is showing evidence that there is a connection between any adverse effect and lung transplant, then I think it would be worthwhile putting it in the policy, but not based off of just anecdotal evidence. So I appreciate that. Thank you.
This is Ginny. So that sounds like this one, we will also skip over the motion for CF agents this month. Is that correct?
Hi, Ginny, this is Marissa. Yes, that's correct.
Okay. All right.
Sorry, Jeannie, can I just make one question? So as we're reviewing this for number 7, should we just make sure that it shouldn't be all solid organ transplant recipients if there's significant interactions with immunosuppressants that are the concern, the safety concern? Not to be, just for next time when we revisit the policy. Thank you.
This is Nancy. I would agree with that. Just to also, I guess, address the significant drug-drug interactions with just transplant medications in general. So we're kind of hitting, we're addressing the issue as well.
Yeah, that I can, we can look into that. And would a statement, just like a blanket statement concerning, because these have many drug-drug interactions in CYP3A4 inhibitors, inducers, substrates of CYP3A, which is the immunosuppressants like tacrolimus, cyclosporin, would a more blanket statement like making sure that all drug-drug interactions are checked be appropriate? That could be something as well.
And hi, this is Donna. I have some follow-up on the lung transplant. So I had looked at other state policies, and the state of Minnesota excluded patients that had had a lung transplant. And the response that they came back was that they had a pediatric pulmonologist on their committee that advised them to exclude the patients with a lung transplant because of the impact on Trikafta on lung function of CF transplant patients was not known. And then there is actually a case report where there had been unexpected detrimental effects on a patient taking Trikafta after a lung transplant. And they sent that to me. And then when they took the patient off of Trikafta, their lung function improved. So it was definitely related to the Trikafta product. And I can forward that to you if you'd like.
This is Alex Park. My concern here is that we're talking about, one or two, there's just not a lot of data, 1 or 2 cases here and there, and there's probably not going to be a lot of experience in the literature on this topic. And to a certain extent, I worry about us doing too much micromanaging. I mean, we want doctors and pharmacists and providers to do their work. We want to trust them to do their work correctly and appropriately.
So we can go ahead and remove that if you like. And that particular item, if we remove that particular item, would you be able to approve the policy as written?
I would be, or I'd be comfortable putting something into the effect of, if patient has had a solid organ lung transplant, that documentation of discussion with the transplant team.
I would rather not do that.
No? Okay.
I would either remove it completely, because if you say documentation, and they're going to deny, a plan might deny it because they didn't have documentation, the proper documentation. And we don't, I mean, that just becomes kind of like another box to check.
Yeah, very point where we'll take me on.
I wanted to be denied if there wasn't documentation, if you thought it was okay to give to a patient with a lung transplant.
Well, I'm not I'm not saying I think it's okay, but I'm saying I trust providers to do their homework on this topic. And CF patients are usually getting the cream of the crop, at least in our state, at dedicated centers. So I would feel comfortable removing this.
Okay. I guess my point was, if a provider had that conversation with the patient and it wasn't adequately documented, I would not want it to get denied due to lack of documentation.
That's a very good point. Yeah.
So having said that, Donna, this is Connie. Is there a way for us to word it, kind of also what Dr. Park is saying, where you don't have to have a required documentation, but we could put a notation saying that patient has been adequately or will be discussed about potential adverse effects or something along that? Can we put a recommendation for providers to be aware of that? So such as patient, so patients with history of lung transplants who have been adequately discussed of potential adverse effects.
Okay, so we'll put a checkbox on the form, and if they check the box, it'll be okay. But if they don't check the box, it'll get denied.
So this is Jordan Starhawk. And what I'm kind of hearing, I think, is we have three options. Either due to our lack of data, we can refuse to do it for lung transplant, or we can make it a requirement that they do something to do this, of which case we risk it's kind of a supervisory role. I guess what I strongly want to suggest we do is try to get into the business of serving as a cystic fibrosis guideline for Washington prescribers. I think that would be a mistake. Personally, my inclination is to, due to the lack of data, to just take number 7 out and trust that our prescribers know what they're doing with this and use our other criteria to approve things. But just have to trust them that they are making wise decisions about this.
This is Ginny, and I would support John's statement.
This is Alex Park. I agree.
This is Ginny again. So if there's consensus on removing number 7, then it sounds to me that we can move like as if we move to a motion.
This is Nancy. What about drug interaction? Do we want to also strike that as well?
This is Alex Park. Did we add that?
Well, I guess it's now the new number 7. Yes. Never mind. I think it's been taken care of, not taken simultaneously. Dropped. Okay. Resolved.
This is Ginny again. We also have a hand raised, I believe, from the stakeholder.
This is Lita. I don't see any stakeholders.
Okay, I thought I saw Lisa Allen's hand up, and I'm sorry, it might have been from a previous.
Oh, I do see Lisa Allen. I'm sorry. Okay, hang on. Go ahead, Lisa.
Thank you so much. Yes, so I really appreciate the discussion about the lung transplant. It really does pertain to all solid organs. And this is something that some CF clinics are exploring in patients, since cystic fibrosis is a systemic disease. And often patients do still need the benefit of CFTR modulators to treat their sinus disease, their GI issues, pancreatic issues, and things like that. Many CF clinics do have CF pharmacists available that carefully are able to monitor in cooperation with the transplant teams the potential drug-drug interactions and adjustment of those dosages. And lastly, that one case report of the 2 patients that had adverse effects on Trikafta after, on top of having had lung transplants, what they were experiencing was what's being called the purge, and they have an acute clearance of a lot of mucus that really affects their ability to breathe, and that caused the shortness of breath, and it was alleviated when they were, the Trikafta was discontinued. But it isn't necessarily detrimental on the lung transplant. It's just the adverse event that some patients can experience as they're starting and they clear out all the mucus that's in their lungs and sinuses.
This is Ginny. Thank you.
Thank you.
Yeah, any additional comments, committee members?
This is Alex Park. This is not a question, but this is an extemporaneous plea, Lisa. I hope that companies like yours are able to really think hard about getting the costs down on these drugs. Thank you.
Thank you, Alex. I understand very much what you're saying.
So committee, let's go ahead and entertain this motion.
This is Jordan Starhaug. I move that the Apple Health Medicaid program implement the clinical criteria listed on policy 45.30.00-2 as recommended, with the exception that the removal of the lung transplant criteria.
This is Ginny. All those in favor, please say aye.
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 Are there any opposed? And the motion carries. And we have one more motion, and that is Apple Health Policy Opioids Update with Ryan Pistoresi.
Good afternoon, this is Ryan. So thank you. I'll try to make this quick, knowing that we are over the 4 o'clock time. So the purpose of today's presentation is to one, go over the information that was presented at the October 2019 DUR meeting. This was related to updates in the opioid policy to add in an MME limit to be compliant with the Support Act. We are also working on a future Support Act implementation that'll go live in 2021 that I will also preview. So, 2 points for today's presentation. Do we have the slides? Yes, that one. Thank you. So we'll start with the slides and do an overview from here. So. Thank you. So as I mentioned, we'll review the changes that occurred to the opioid policy in November, and also a preview of the upcoming changes for 2021 regarding checking the prescription monitoring program. On the next slide is just a timeline of the different changes that we have made over the last few years. So in 2017, we made the first major update, which added the acute and chronic limits. So the 42-day supply cutoff going between acute and chronic. We also created expedited authorizations that allowed overrides for the provider discretion for the acute limits, and we also created the opioid attestation form for chronic opioid use. Last year, we updated the attestation form to include authorizations for prescriptions over 120 morphine milligram equivalents per day to align with the requirements of the Support Act. So the Support Act mandated that states have an MME limit in place for their opioid prescriptions, and we look to align that by using the state's 1427, House Bill 1427 work group recommendations that then were put into the Washington Administrative Code for the 5 boards and commissions that prescribe opioids in our state. And then also in next year in 2021, we will be creating new guidance for how providers can check the prescription monitoring program prior to prescribing and dispensing prescriptions. So it'll be slightly different between the prescribers and then the pharmacists who are dispensing these prescriptions. On the next slide is just a quick overview of the changes for 2019. So the Support Act was federal legislation that passed in 2018 that directed federal agencies to focus on the opioid crisis that is occurring across our country. And one of the sections, Section 1004, was specific to how state Medicaid agencies can address it through opioid clinical policies. On the next slide is a little bit more detail about Section 1004, which really directed states to develop their own MME criteria. So because different states had already developed their own MME criteria, the federal law just directed states to develop their own state-specific ones. And because it was a state-specific one, we looked at what work was already being done in our state around MME limits. And there was already a work group going on for the implementation of engrossed substitute House Bill 1427 that was creating criteria around high-dose opioid prescriptions. So the consult and the exemptions that we derived from the WAC were put into the policy and also updated on our attestation forms. So we created that criteria so that it applies the prior authorization criteria for claims that result in either alone or in combination a daily MME of over 120. But it does allow the providers to attest that they have completed the consult with a pain management specialist or that they meet one of the exemptions as it is outlined in the WAC. And so the WACs are dependent on the different boards and professions that are applicable to that provider type. So this is our attempt at really aligning with what clinical practice guidelines were for the providers in our state when we implemented this also in 2019. For claims that are over 200 MME, it does require the completion of an attestation and that the supporting documentation or the chart notes be submitted to HCA for review. This helps us better understand what clinical documentation and the rationale for the medical necessity for these treatments that are over 200 MME per day. And so this should be, specific to the requested dose. So if someone is, elevating their dose from 200 to 300, we would require the rationale for a jump like that. And this was presented at the October 2019 meeting. It was presented as information only then. The reason that we're bringing it back and recapping this is that we did not have a DUR board motion for that policy that was finalized. And so we are bringing that back today with a board motion for you to make on the MME specific criteria. And we do have the policy and the pinned form. I think they were up on Marissa's screen, prior to transitioning over to the slide, so we will be able to look at that once we get to the board motion. But for the rest of this presentation, we'll just be highlighting the upcoming changes, so that way you are aware of what we are doing to implement Section 5042 of the Support Act. So in October of next year, we will be updating our clinical criteria to provide the guidance for how providers can meet this new federal law. So this is important to note that this is for all controlled substances and not just opioids like the previous other policies. But because this has a direct impact on opioids, we are bringing it here today and putting it in with the opioid policy. But do note that this law, which is now codified in the U.S. Code, is for all controlled medications. And the quotation there at the bottom of the slide is, kind of the relevant part of the law that we are going to focus in today. So these are going to be updated also in our administrative code. We'll also be updating our billing guides to outline what is now expected. And in order for us to meet the compliance with the federal law, we're going to be publishing the clinical policy. We're going to be creating a compliance monitoring process, of which we are required to report annual reports to CMS. And we're also going to be providing communications. And this presentation today is, one of the many communications that we are working on. We have also reached out to the different boards and commissions through DOH. We've also reached out to the different health professional associations in the state about this. But you are actually one of the first ones that we are actually doing a full presentation on about this. So the new clinical policy, so in order for the prescribers to meet the intent of the federal law, we are guiding providers that prior to writing a prescription for any controlled medication for a Medicaid patient, that they must check the Washington State Prescription Drug Monitoring Program no more than 10 days prior to writing the prescription. For pharmacists who are dispensing these medications, they would be required to check the PMP no more than 48 hours prior to filling and dispensing that controlled medication to that client. And that these would be added to our WACs and provider guides. And what's important to note is that unlike the other clinical policies that we put in place in 2017 and 2019, that this is not going to stop or limit opioid prescriptions. This is intended, for the provider to use these tools to get more information about the patients that they are treating, to be able to look at a full current prescription drug history for these clients, and to use that information when making decisions about the treatment plans that are right for them. So we are not going to stop opioid prescriptions and say, did you check the PMP, 10 days prior to writing this prescription or prior to dispensing this, and then, potentially stop the patient from getting their medication. This is a tool that is being used, to help provide education to our providers, prior to caring for these patients. So there are no new limits being applied to opioid or controlled substances as a result of this new policy. So the providers and pharmacists, need to review all of the current prescriptions that are documented in the PMP. That the providers and pharmacists are able to delegate this review to anyone within their practice setting with an authorization to access the PMP, so long as they provide the provider and the pharmacist the opportunity to review all of the current prescriptions prior to either writing the prescription or dispensing that prescription. And in order to document this and to verify that this check did occur, that they would review that and document the time and date that this occurred in the patient's record. We do know that sometimes the PMP is not available, or that there are other emergencies that are going on in which it is not possible to access the PMP, and so that there is a good faith effort that would be acceptable if they are not able to access the PMP, but they intended to do so and are able to do so when the PMP is available. The new monitoring program that we are developing here at HCA will measure the amount of qualifying checks that prescribers, pharmacists, and their delegates do. So we are working with our partners at the Department of Health in order to develop these reports. So that way we can measure how often prescribers and pharmacists are checking the PMP within these limits. We will be using our claims data to identify the date that the prescription was written and that the date the prescription was filled and dispensed to the client, in order to be able to verify that these checks that occurred on this patient occurred at these dates. In the event that we need to do any further in-depth reviews, we would be able to look at the notes that show that when a date or other good faith effort was done, would count as a qualifying check, so long as they were meeting the intent of this policy. We are considering sending out educational letters to prescribers and pharmacists who are below 80% qualifying checks. We had some success in the past with previous letters that were sent to prescribers relating to opioid treatments. And we are considering using a similar model for that in order to help prescribers and pharmacists check the PDMP. And then we will need to be reporting this to CMS. Our first report we anticipate will be due at our Drug Utilization Review Report, which is due June 30th of 2023. Next slide. And so we are creating a robust communication plan. So as I mentioned, we had already reached out to the boards and commissions, the state health professional organizations, and even here today. And we are looking at, getting the message out, prior to this going live for October. And we do have a few key messages that we have listed here that are central to our communication plan. And then here's a bit of information about where we are putting these updates related to Support Act implementation. And then that is a hyperlink to our Apple Health Pharmacy Policy mailbox here at HCA, which we are using to track and triage these questions. And so this is the end of this presentation. If we want to pull up, the policy or the form, we are able to do that. But I realize, we are a bit over, and I wanted to open it up to the P&T DUR board to see if there are any questions or comments on this.
Thanks, Ryan. This is Jenny. That is really informative and helpful for us to hear. I don't have any questions, but I want to turn it over to my fellow board members. I don't want to jump the gun, but I also don't hear or see anybody popping in. It sounds as if we need to make a DUR motion to add to our to the motion that was done last year. Is that right?
Yeah, hi, this is Ryan. And so, so we do have the motion up. So this is for the policy effects that went live on November 1st, 2019, related to NME requirements that are compliant with Section 1004 of the Support Act and that are aligned with the boards and commissions rules that went into effect on January 1st of 2019.
This is Jordan Starhouse. Ryan, could I ask you a clarifying question?
Yes, certainly.
For patients who transfer onto Medicaid but have been previously on chronic opioids, it seems the workflow now is a person's not able to do a chronic opioid attestation for that person until they've completed 42 days. Is there another workflow that those patients should be going through, or does the system kind of make them an acute user for 42 days and then can get to the typical procedures?
That's a great question. I'm pulling up the attestation form just to see how we had accounted for that.
Hey Ryan, this is Amy. It's actually accounted for using one of the expedited authorization codes. So the pharmacy would recognize that the client was previously established on chronic opioid therapy and would enter the expedited authorization code and the claim would pay.
So if we're having problems, this is a Jordan Star again. So if there's problems, it's a pharmacist who doesn't know the right code to submit, it sounds like.
Possibly, yes. There's been several different pathways that things could go down, but that could be part of it. It could be that maybe they're going to a pharmacy where they don't have the established history, whereas the provider can actually see that. The prescriber can see the history, but they may be at a pharmacy that they haven't filled before. There's been several things that have popped up.
Right, and so if there is a so this is Ryan Pistoresi again. So if there is a specific case that has been causing you issues, you know, can we recommend that you email us and, you know, we can see what we can do in order to, you know, assist if this is, you know, a common issue.
Are there any other questions? This is Jenny. Do we, I wonder if I could see who's still here. I want to make sure we still have a quorum of committee members. Here you
This
are.
is Lita. I just checked on that too, Jenny. We do.
Okay. All right. Any other questions?
This is Nancy. I move that Apple Health Medicaid program implement the clinical criteria listed on policy 65.10.00 as recommended.
This is Susan Flattabo. I second.
This is Jenny. All those in favor, please say aye.
Aye.
Are there any opposed? And this final motion of the day carries. So that looks as if we've made it to the end of the agenda. Are there any comments from Lita or from Donna before we go?
This is Lita. Thank you guys so much for finishing the agenda.
Yeah,
First time we've ever gone over.
I want to ditto that, and thanks for just serving on the DUR board. I know it sometimes isn't the funnest job when we're having a lot of opposition from stakeholders. So I really appreciate all of the work that you do. Thank you.
Thank you. Thank you guys.
Thanks, everyone.
Have a great holiday.
Have a great holiday season.
Thank you all.
Happy holidays, everyone.
Bye, everyone.
Thank you.